Okay, guys, we're just going to do the pathophysiology of some of the vascular disorders that we're going to study in cardiac. And so the first one is chapter 38, PAD, and it's on page 833. There's a great picture on page 834. Shows you essentially where the most common sites for PAD developed. What happens with PAD is that we have a narrowing of the arteries, and this narrowing is typically due to atherosclerosis. We've already talked about atherosclerosis and what it is, and it affects the intimal, or the most inner lining of the artery, and then involves also the medial or mid layer of the artery and causes a narrowing. Risk factors are very similar to those for CAD. You know, someone who uses tobacco, is diabetic, has high lipids, positive C-reactive proteins, blood pressure is not controlled. This is the info we just went over, but you know, what is happening with PAD is it leads to complications, and these complications have to be dealt with. And so this is an individual who, for instance, has delayed healing. You know, they get a foot ulcer and it will not heal quickly, or maybe it won't heal. The foot ulcer or the leg ulcer gets infected and could actually become gangrenous and require amputation. The signs and symptoms of PAD include what we call intermittent claudication. So this is essentially angina of the legs. We talked about supply and demand when we talked about coronary artery disease. Well, intermittent claudication is all about supply and demand. A individual walks, you have decreased circulation because of the narrowing of the arteries, and therefore not enough blood flow is getting to the distal portions of the leg, and the patient develops intermittent claudication, or leg pain or angina of the legs. They rest, and within 10 minutes typically the pain will go away as supply and demand equals out. These individuals can also deal with what we call paresthesia, which you guys know is the numbness and tingling. In the lower part of the extremities, that their skin can actually get rather shiny looking, thin looking, taut looking, and they can actually have hair loss in the lower legs. Their pulses can become diminished. They can have what we call rest pain. This typically happens at night because, you know, as you sleep, cardiac output goes down and there is not enough oxygenated blood and nutrients getting into the distal ends, the toes, the feet, and they develop pain at night when they're doing absolutely no activity at all. This pain can be aggravated if you would elevate the extremities, because once again, if you elevate the extremities, you're decreasing arterial flow. Also, what you'll notice is leg elevation also can cause a paleness in the feet. Okay, you can do diagnostic studies to find out where PAD is occurring. Remember, we want to make sure that this individual is being closely monitored for their hypertension, their diabetes, their lipid levels. You can do a Doppler ultrasound, which just would map out the artery and show us exactly where the occlusions are in the artery. Segmental blood pressure readings, doing the thigh, the knee, and the ankle, and watching for a 30-point or more greater drop. You can do ABIs, Ankle-brachial index. So what essentially you do is you take the blood pressure of the foot that you believed is involved. So let's say we think it's the right foot, okay? And then you would take a normal blood pressure, brachial blood pressure, both in the left and the right arm, and whichever one is the highest, then you would take the highest pressure of the arm, and that's what you're dividing the right foot blood pressure by, and you would get what we call the right ABI, okay? And as far as the right ABI and significant readings, if you look at page 836, you'll be able to see that if it's less than 0.9, then it becomes abnormal. You can do an angiography. This is much like a cardiac cath, but of the lower extremity arteries, where you go down to invasive radiology and you shoot dye into the artery, you map out the artery, and you can actually see where the narrowing or possible occlusions are. So key to the management of PAD is obviously risk factor modification. We've talked about the fact that if someone is smoking, that's the first risk factor that we go over. And so we want to talk to them about stop using tobacco products. We want to have aggressive treatment of their hyperlipidemia, their high lipid levels. During coronary artery disease, we talked about the statins. The statins are actually used to manage hyperlipidemia for PAD also. We want to make sure that their blood pressures are well maintained, controlled, taking their antihypertensives, which we've already talked about. And that, if we can get their hemoglobin A1Cs less than 7, the closer to 6, the better. So we will start then in class talking about drug therapy and exercise therapy and the rest of the nursing interventions that we would have for PAD. Okay, guys, we are actually flipping to veins, so we're on page 847. Okay, so you guys had this in fundamentals, so you know what's going on here is that you have a vein that has some inflammation in it. Lots and lots of reasons why a vein might become inflamed. Reasons listed on page 848. We have what we call the Virchow's triad, which where you have the venous stasis or the decrease in the blood flow. You actually have something that has led to endothelial damage, or you have blood situation where it clots too readily. So you can review all this information on page 848, but you have an inflamed vein and you have a clot that forms, and that is called a venous thrombus. Okay, so we can have signs and symptoms kind of depending upon whether it be superficial or deeper, and we're on page 849. Superficial would be more that it's closer to the surface. You may actually see a vein that is palpable, and when you palpate it, it actually feels firm. The patient may complain that it feels itchy and they need to scratch, might have a little bit of tenderness, might have some redness, a little warm. Compared to a deeper venous thrombus, usually in one of the lower extremities, we have some swelling. The patient complains of pain, of fullness in the calf. They say it feels tender. Maybe you have warm skin. It's reddened, and you could possibly have an elevated temperature. Diagnostic-wise, typically do a duplex ultrasound, just like we were talking about for PAD, maybe a venography, and check their clotting studies and a SED rate to see if they have an inflammatory process. So what we need to do is prevention and prophylaxis. So we identify those individuals that are at risk, and we place them prophylactically on a blood thinner. We'll talk more about this in class. And we do all the preventative measures that we talked about in fundamentals or MP1. I wanted you to know and introduce the concept of what is called a core measure. And the core measure is just a set of care standards. They're instituted by the Centers for Medicare and Medicaid Services, the CMS, and it actually outlines how care should be provided to certain patients while they're in the hospital. And these standards or these measures have actually shown to prove outpatient patient outcomes. And so that is called a core measure. Well, the prevention of DVTs is actually a core measure. And so that's something that I wanted you guys to know. And so it means it's very specifically going to outline what it is that we should be doing for these patients to prevent DVTs or venous thrombus, and that if we don't do this, then they could be fined, or if someone would develop a DVT or venous thrombus while in the hospital and they did not follow core measures, then Medicare, Medicaid will not reimburse them. And essentially where Medicare and Medicaid lead the way in insurance, all private insurance fall into suit.